So pelvimetry has been taken from two terms. One is your pelvi, another one is your metry. So what is metry? Metry means measurements, right? And pelvi means pelvis. So pelvimetry has been taken from two terms. One is your pelvis, another one is your metry. So today we will be dealing with various measurement of the pelvis. So why pelvimetry is necessary? Because why this bone itself is necessary? Okay, let us go one by one. So as the definition says, pelvimetry is the measurement of the dimension of the pelvis, various dimensions of the pelvis, and it is of two types. One is your clinical pelvimetry, which is carried out by a doctor, and another one is your radiological pelvimetry, which is carried out by various radiological modalities such as X-ray, CT scan as well as MRI. Why I have written MRI as the safest machine? Because this is an X-ray machine where X-ray radiations are used, and this is a CT scan machine which looks similar to an MRI machine, but in CT scan we usually use radiation. What is a CT scan? Is basically it is a modified version of X-ray only. In CT scan we cut the whole layers slices by slices, and we take imaging of each one of the slices, that is CT scan. So based on whether we use any contrast or not, we divide the CT scan into contrast enhanced CT scan, that is CECT, or non-contrast CT scan. So here basically in CT pelvimetry as well as in X-ray, various rays are used, and pelvimetry is something which usually we measure in a pregnant female. Usually we measure in a pregnant female. That is why pelvimetry, and as such the whole topic of pelvimetry becomes so much important, because this is basically a core gynae topic, obs-gynae gynae topic. During our times it was not that much important in first year, but in your recent CBME guidelines it has been given in your competency. So just have a basic idea of the whole thing. Now the clinical pelvimetry, that is clinical pelvimetry is done by a doctor. So the doctor basically uses two fingers and insert into the vagina of the female, pregnant female, and by this they determine the various position of the baby, the station of the baby, as well as whether the pelvis or the vagina is sufficient for a normal vaginal delivery or not. By this they usually determine. When you will be doing internship, you will also be doing the same thing. If your setup permits you to do the normal vaginal delivery, then you will be performing the normal vaginal delivery, because in most of the setup normal vaginal deliveries are carried out by interns, most of the setups. And if the number of deliveries are less in number in your setup, which we will see in future, so depending on that it will be carried out by PGs or your seniors. So but the basic measurements has to be taken by interns. Okay, so clinical pelvimetry, using two fingers we determine whether the baby's station or the head of the baby has come down or not. And then suppose this is your pelvis, so by inserting, suppose this is the vagina, so it is according to the axis of your pelvic outlet. So after inserting the fingers, we check these borders, these ischial spines we check, then we try to palpate the pubic ramus, and by seeing this we have a certain understanding of the various diameters, and after having an understanding of the diameters we can easily say that whether there will be any capalo-pelvic disproportion or not. What is capalo-pelvic disproportion? Is capalo means head. So basically we are talking about the head of the fetus and the pelvis of the mother. So whether there is any disproportion or not, basically today you are having two classes, so I will be finishing by 10-15 minutes. Okay, so in capalo-pelvic disproportion we measure the head of the baby. So if the head of the baby is large enough for the pelvis of the mother, then we usually perform LSCS, that is cesarean section or lower segment cesarean section. But if the disproportion is not there and we can see that the head can easily pass through the vaginal route of the mother, then we usually prefer normal vaginal delivery. But now in recent studies it has been seen that even if there is capalo-pelvic disproportion present, then also in certain way normal vaginal delivery is carried out. So for this purpose we need to do the clinical pelvimetry. And in radiological pelvimetry basically we do MRI, then USG sonography. In sonography you can easily see the various, like in sonography also there are certain modalities. There is transvaginal sonography, abdominal sonography. So in transvaginal sonography, you can determine the pathway of the mother, that is the birth canal. So here you can determine all the radiological measurements, okay, whether the diameter is perfect or not for the normal vaginal delivery. So that is why pelvimetry is of two types. One is your clinical, another one is your radiological. Now coming to the bony pelvis, the bony pelvis comprises of your sacrum, coccyx and your two hip bones. Sacrum, coccyx and your two hip bones. Now coming to this picture, here I want you to see this pelvic brim. If you cannot see it properly here, try to see this picture. So here the pelvis has been kept like this. So this is your pelvic brim. And just above the pelvic brim, this portion is your greater pelvis or your false pelvis. This greater pelvis is basically bounded posteriorly by your some portion of your promontory and your lumbar vertebra. Then on either side by the iliac fossa, and in anteriorly by the anterior abdominal wall, which is basically the free wall. So the greater pelvis is actually the false pelvis, and the lower pelvis or the lesser pelvis is actually the true pelvis. This true pelvis is further divided into your pelvic brim, pelvic inlet, pelvic outlet and pelvic cavity. This pelvic brim is dividing the whole pelvis into your upper and lower segment. Then comes your pelvic inlet, pelvic cavity and your pelvic outlet. So pelvic brim is formed by behind by your sacral promontory, on either side by your arcuate line of ilium, and in the front by your pecten pubis, pubic crest. So this pecten pubis, pubic crest and arcuate line of ilium together they form the linea terminalis. So see this bone, here you will see this posteriorly sacral promontory is forming the posterior part of your pelvic brim, and on either side this arcuate line of the ilium is forming your lateral two parts of your pelvic brim, and anteriorly you are having this pecten pubis, pubic crest as well as the pubic ramus and pubic symphysis. So together this whole thing is forming your linea terminalis. So this is your pelvic brim, this portion. So above this part is your greater pelvis, below this portion is your pelvic cavity having the pelvic inlet and the outlet. Now here you see certain ligaments which are important. So if you have attended the vertebral class, I have told you that in the anterior part you have the anterior longitudinal ligament. Now on either side you have the iliolumbar ligament starting from your lumbar vertebra and your ilium. In between there is iliolumbar ligament. Then here is your sacrotuberous and sacrococcygeus ligament. Sacrotuberous ligament starting from the sacrum up to your ischial tuberosity, and sacrococcygeus starting from the coccyx up to the sacrum. So you have remembered na, in your gluteal class that this sacrotuberous and sacrococcygeus ligament is converting your greater notch and lesser notch into greater foramen, greater sciatic foramen, lesser sciatic foramen. So these are the structures. Here is your obturator foramen having the obturator membrane. Now that's all. And this is the subpubic angle. Basically this is your subpubic angle which we will be discussing later on. This is the subpubic angle. Now sex differences. Actually this is the old slide. Yesterday I have shown another slide. Just the same thing only. This is a bit complicated one. Here you can see I have taken this from your Visham Singh, but yesterday I have shown from another book. So here it was in a more like easy way it was written. So let me just give you a brief introduction to the whole thing. Everything in male and female, there is only 3 points to remember, that everything will be larger and wider. Whatever the points are there, everything will be larger and wider in case of female. Only O, S, A. These are the three things which will be wider and larger in case of your males. O means obturator foramen, S means sacroiliac joint, A is acetabular notch. So basically this acetabulum will be more wider and larger in case of male. Then this obturator foramen will also be wider and larger in case of males, and this sacroiliac joint will be wider in case of males. Rest all the structure will be more wider, bigger, larger in case of females. Suppose starting from your general structure, female pelvis is light and thin, male will be heavy and thick, leave it. So articular surface will be large in case of male. Basically the articular surface of your sacroiliac joint, then your acetabular notch, these things will be large in case of male, small in case of female. Then pelvic inlet will be heart shaped in case of male mostly. So this is almost a heart-shaped pelvis, but by seeing the size of the pelvis, you cannot determine whether it is a male pelvis or a female pelvis, because on the later slides you will see that there are certain female pelvis also, which are anthropoid pelvis, or either anthropoid or android, we will see, which more like a male pelvis, but it is present in female. So acetabulum will be large in case of male, ischial tuberosity will be interned in male, female acetabulum will be small, and obturator foramen is larger and oval in case of males. Now see this structure. So basically this is the pelvic inlet in a male, that is the pelvic inlet in case of female. Now try to understand this. This is more of a theoretical part. Here the first thing in case of male, it is saying that it is a small portion of a long segment of a short cone. So suppose this is a short cone, and if you take a long segment, then it appears somewhat like this. This is your male pelvis. But in case of female pelvis, it is short segment of a long cone. So suppose this is a long cone and you are taking a short segment. So on either side, the pelvic inlet in case of female, it appears parallel. So the pelvic inlet in case of male, it is more of a conical in shape. In case of female, it is more of a cylindrical in shape, just this thing. And this is your subpubic angle, basically your this angle, just on either side of your pubic symphysis as well as your pubic ramus up to this ischial tuberosity. This is your subpubic angle. So if the angle is less than 90 degree, then it is a male pelvis, and if the angle is more than 90 degree, then it is basically a female pelvis. We usually measure this using your finger. Where it will be more useful, this 90 degree funda, because in case of a live person, you can easily say that this is a male, this is a female, so no use of checking this subpubic angle. So basically we check the subpubic angle in case of forensic studies, whether there are any bony pelvis found in a cremation ground. Now I need to know whether it is a male or a female pelvis, so in that case we use this subpubic angle to determine whether it is a male pelvis or a female pelvis. Now coming to true pelvis proper. So the true pelvis is the lesser pelvis that is present below the pelvic brim. As I have already mentioned, it is divided into pelvic inlet, pelvic outlet and the pelvic cavity. So the pelvic inlet will be present just beneath your pelvic brim, and it will be bounded posteriorly similar to the pelvic brim by your sacral promontory and your anterior margins of ala of the sacrum, that is this part. This is your pelvic inlet. So this is your pelvic brim, and just beneath this is your pelvic inlet, which will be having posteriorly your sacrum and ala of sacrum. Then on either side your arcuate line of ilium, arcuate pectineal line, and in front by your upper margin of pubic symphysis. So this is the pubic symphysis. So the upper margin of pubic symphysis will be forming the anterior boundary of your pelvic inlet. Now the pelvic outlet is more of a diamond shape. Okay. So this is the ischial tuberosity, and here will be two ligaments going, which are the sacrotuberous ligament coming from the sacrum up to the ischial tuberosity. So sacrotuberous ligament, which is obviously not present here, it is present in a live person. So if two sacrotuberous ligaments come like this, and this is your ischial tuberosity, this one, so it is forming a diamond shaped structure. So if it is forming a diamond shaped structure, then it will be having a posterior surface, anterior surface, anterolateral surface, posterolateral surface. So accordingly, posteriorly will be your coccyx, what is written here. So pelvic cavity, posteriorly will be your sacrotuberous, posteriorly will be your tip of the coccyx. So tip of the coccyx will be present posteriorly. Posterolaterally will be your sacrotuberous ligament. Anterolaterally will be your this pubic ramus or ischial tuberosity, and anteriorly will be your lower margin of pubic symphysis, that is this part. So this is forming your pelvic outlet. Now we have talked about this pelvic brim, then pelvic inlet, then pelvic outlet. Now what is left is the pelvic cavity. So the space between your pelvic inlet and your pelvic outlet is your pelvic cavity. So the pelvic cavity is basically bounded by your pelvic organs. So anteriorly it will be bounded by the pelvic surface of the body of the pubic bone, that is this part. posteriorly by the pelvic surface of your sacrum and coccyx, laterally by the pelvic surface of your ilium ischium below the arcuate line. Below the arcuate line because it is forming the pelvic brim, this arcuate line. So this is your pelvic cavity. So this is the true pelvis in proper. Now these are the types of female pelvis. As you can see, the normal one is a gynecoid shape. It will be having an anterior-posterior diameter less than the transverse diameter. Come. Anterior-posterior diameter less than the transverse diameter. This is the anterior-posterior diameter. So this is basically an ideal pelvis where normal vaginal delivery occurs very smoothly. And this is the case in almost 40 to 50% of adult females. But the next most common is your android pelvis, which is a male type pelvis in a female, where normal vaginal delivery is a bit difficult. Then the platypaloid type is further tough pelvis, which will be having a flattened pelvis. So here the pelvis will be compressed, more compressed. Okay. So the inlet is anterior-posteriorly compressed, and anthropoid pelvis will be compressed by laterally. So in both this thing, normal vaginal delivery is very difficult. But in case of gynecoid and android, normal vaginal delivery is more of a easy type. What is labor? Here I have written may result in obstructed labor. Basically this is also from your Vishram Singh. Everywhere the same picture is given. So what is labor? So basically labor is the whole process starting from the contractions in the mother up to the delivery of the baby, then followed by delivery of the placenta. The whole process is labor. Okay. So starting from the contraction, so basically the contractions keep on increasing 6 to 8 hours, or almost you can say up to 12 hours before the baby is delivered. So from that portion we are dividing the whole labor into 3 phases. First of all, your beginning of the contraction, followed by delivery of the fetus, followed by delivery of the placenta. This whole phases will be comprising your labor phases. Okay. So labor will be more difficult, or okay, here it is written may result in obstructed labor. So sometimes the mother is in contraction but the baby cannot come out of the mother's body. That is, the fetus cannot get delivered. That is an obstructed labor. If you see that there is any case of obstructed labor, the patient should be, or the pregnant mother should be immediately transferred to cesarean section. So the normal vaginal delivery is carried forward into your emergency cesarean section if requirement is there. Now these are the pelvic planes. So basically this is the anatomical position of the pelvis. It is not present like this, kept like this. It is kept somewhat anteriorly and forward, bending downwards. This is the position of your anatomical position of your pelvis. Just make sure that if this is your horizontal line, this sacral promontory or the top of the sacral promontory and this top of your pubic symphysis, together they are forming 50 to 60 degree with your horizontal plane. So it is present like this. Now here anterior-posteriorly, here this is the greatest dimension of the pelvis. So there are certain dimension of the pelvis which we need to memorize, like diameters of pelvis which we need to memorize. So this is the plane of the greatest pelvic dimension, starting from the posterior part of your pubic symphysis up to your S2 and S3 sacral vertebra, and this is the plane of your greatest pelvic dimension. So through this part a baby can easily come out, and this is the plane of your least pelvic dimension anterior-posteriorly, and transversely this is your ischial spine. This is the plane of your least pelvic dimension. Now there are certain conjugate diameters. Conjugate diameters are your anterior-posterior diameters. Those are called as conjugate diameters. Basically this is important for a female pelvis. So here you can see in the just behind the pubic symphysis, we are taking 3 measurements. One is your just from above the pubic symphysis up to the sacral promontory. We are calling it true conjugate. Then just behind from the midpoint of your pubic symphysis up to your sacral promontory, which is your obstetrical conjugate, and just from the lower portion of your pubic symphysis up to the sacral promontory, which is your diagonal conjugate. So there are certain measurements for this, And your external conjugate is basically from the anterior part of your pubic symphysis up to the posterior part of your sacral vertebra. Now these are the antero-posterior diameter as well as the transverse diameter. So this is the antero-posterior diameter of your pelvic inlet, starting from your pubic symphysis up to your sacral promontory, which is around 11 centimeter. So here you can see that this antero-posterior diameter is the shortest diameter in case of your pelvic inlet, and this is the oblique diameter from on either side of your arcuate line. Then there is an oblique, so this is the transverse diameter, and this is your oblique diameter stretching from your sacroiliac joint up to your pubic crest. This is the oblique diameter. So in the pelvic inlet you will see that the antero-posterior diameter is the shortest one, that is only 11 centimeter. So similarly on the pelvic outlet, here the opposite thing happens. The antero-posterior diameter is the longest one, that is 13 centimeter. So these are the various measurements. So here as you can see that the antero-posterior diameter, that is this diameter, is more in case of your pelvic outlet, but it's the least in case of your pelvic inlet. So what this depicts is that while delivering, the head of the baby gets most obstructed at the pelvic inlet, but as the head passes from here, you will feel that there is a loss of resistance. So after that the baby can be easily pulled out when the head is present in the pelvic outlet level, because here the antero-posterior diameter is more. Here also you can see here this antero-posterior diameter, the sacral promontory comes forward, so the antero-posterior diameter gets reduced. But once it crosses, here you can see there is a curve which is increasing your antero-posterior diameter. So that is why on the outlet level the antero-posterior diameter is longer. Similarly, there are various measurements for your oblique as well as transverse diameter which you need to memorize. Then there is one clinical anatomy which we need to learn here. So what is this? Can you understand the X-ray? So here basically you can see these two hip bones, that is your ilium, ischium, pubis. This is your ischial tuberosities. This is the head of the femur. This is the head of the femur. This is your femur. Then posteriorly you can see this lumbar vertebra. Then some portion of your sacrum also you can see. You can see this sacroiliac joint on either side. What is this? So this is basically an X-ray of your pelvic fracture. This is pelvic fracture. So pelvic fracture is not that much common because pelvis is a very complicated bone, so the fracture is not that much common in case of pelvis. But if fracture occurs, tell me one injury that you have studied in your class which occurs in pelvis fracture. What viscera get injured in pelvis fracture? So your urethral injury occurs in your pelvis fracture. So which urethral injury occurs in pelvis fracture? Posterior urethra. So basically the urethra is divided into four segments. One is your penile urethra, then your bulbar urethra, membranous urethra, and your prostatic urethra. So suppose this is the penis. So here will be your penile urethra. Then comes your bulbar urethra. Then comes your membranous urethra, and finally your prostatic urethra. Here will be your bladder. Now here there is one segment which is known as verumentanum. Just leave this thing. So this is your penile urethra, this is your bulbar urethra. Now in case of any straddle injury, what is straddle injury? Straddle injury means a person is walking on a road and suppose he fell on the manhole. So during that type of injury, anterior urethra gets damaged. Anterior urethra is formed by your penile urethra and your membranous urethra. Sorry, bulbar urethra. These two structure forms your anterior urethra. Posterior urethra is formed by your membranous urethra and your prostatic urethra. So this is your posterior urethra. And this posterior urethra usually gets affected in your pelvis fracture. Okay, so in any road traffic accident, the posterior urethra gets affected. In case of straddle injury, the anterior urethra gets injured. Okay. So that's all from your pelvimetry. So I am telling you what to study from pelvimetry. Basically, pelvimetry will be comprising only some portion of your exam. So just prioritize the whole topics. So osteology will be having only 10 or 15 marks. So for that, after leaving all the bones, there is only small portion will be asked from these bones. So basically you will be told to just tell the name of the bones and what are the structures, what are the boundaries of pelvic brim, pelvic inlet, pelvic outlet. And after you have answered this question, then question will come for your various diameters, anterior posterior diameters. So prioritize the whole topic like this. Basically try to study the basic things first and then go to the diameter later on. That is why I have kept the diameter. Like there are various other diameters, true conjugates, obstetrical conjugates. Other than these also there is a long chart. Basically how the baby will be on various diameter, like occipito-anterior diameter, occipito-posterior diameter, right occipito-anterior diameter, flexion is there, extension of head is there, depending on various diameters. So we don't need these things for the first year MBBS. Okay, that is why I have kept just the anterior-posterior, transverse and the oblique diameter for the inlet, outlet and the cavity. So try to memorize that table only, that is this table only, and try to study these basic things, and finally this part. Okay, what is the bony pelvis comprising of? Okay, that will be sufficient for your exam. Okay.